seminar geared around men's health, in particular erectile dysfunction. I do want to take a minute to thank Dr. Siegelbaum for providing us with his wealth of knowledge in this arena. A little bit about Northern is that we are a full service pharmacy. So albeit I am the compounding lab account executive, we have multiple facets to the pharmacy and can provide multiple options within the retail pharmacy, compounding pharmacy. We have a medical equipment and supplies division, as well as a specialty pharmacy as well. Dr. Siegelbaum, do you mind flipping for me?
Well, yeah, I got it.
Thank you. Thank you, I appreciate it. On this, you can see at the top there, it just lists the different divisions that we have. And this slide in particular is going to tell you how to get in touch with any of the departments within Northern Pharmacy as a whole. And I do believe this is being recorded, so if you ever need to refer back to it as well, it will be available to you. Dr. Siegelbaum, I'm going to turn it over to you.
Thank you, Corey. I appreciate you sponsoring this lecture tonight, and I appreciate Boston Scientific sponsoring this lecture tonight. It is an educational lecture, and it's meant for that purpose. But just as an FYI, these are two vendors that I deal with, almost every single day of my professional life. I send patients to Northern Pharmacy, not because I have any kind of business relationship with that pharmacy whatsoever, but I use that pharmacy because I think they do the most excellent job in terms of compounding some of the medications that, in fact, we're going to be talking about in the lecture tonight. I find that they're incredibly reliable. They are service-oriented and manage to get the products to the patients when they need them and very quickly. So from a service point of view, my patients are always uniformly extremely happy with what Northern Pharmacy can provide. So thank you. And some of the products that we're going to be talking about later in the discussion tonight about the penile prosthetics that's made by the Boston Scientific Organization. These are prosthetics that I put in all the time and use them all the time. They have to be safe. They have to be reliable. And I have these lectures because I truly do believe in what it is that I do for patients that suffer with ED, and it's a great product line. So thank you both for sponsoring. I'm Dr. Siegelbaum. I'm the head of urology at St. Joseph Medical Center, University of Maryland. I'm also the director of the ED department at Chesapeake Urology, which is a private urology group, but just a large one. My particular interest in ED sort of emanated from the fact that I really am mostly a cancer surgeon. I've been a cancer surgeon my whole career. And then when robotic surgery became popularized, at least for me, that was 17 years ago, believe it or not, I ended up doing an extensive amount of prostate and bladder cancer surgery. And as a result of a lot of those surgeries and as a result of radiation treatment for a lot of those kinds of cancers, which we'll talk about also tonight, a lot of men do suffer from erectile dysfunction. And I wanted to make sure that if I was treating these patients' cancers, that I had the ability to also treat their erectile dysfunction. It became very empowering for me and empowering for them to have a physician that not only can cure their cancer, but can take care of any side effects that may result from the treatments. So that's how I evolved into an ED surgeon and ED treating physician. So that's my background, and just wanted to let you know a little bit about that. So we can go right into the discussion specifically tonight about ED. So let's talk about what is it? What is ED? Just to make sure we have our definitions in line. It's basically the inability to maintain an erection that's firm enough for sexual intercourse. You don't necessarily have to have an erection to have sex, so to speak, but to have intercourse, you do need to have a proper erection that's firm enough. And ED is incredibly common. It's amazing that in the beginning of my career, patients would almost never talk about this. And now in the latter parts of my career, that's all they ever talk about, it seems, because it is a very pervasive problem, medical issue. And you can see that 1 in 5 American men who are older than 20 years or 20 years or older will eventually experience ED in their lifetime. That means 20% of all men will have this issue. And currently, as you get older, so as you move into your 40s, about half of the men who are age 40 and over are going to have some degree of ED. It doesn't mean that they're suffering from severe ED, but they're going to have some form of it. And across our country, in the United States, about close to 40 million men will experience some issues with ED. So again, it's very, very pervasive. Let's talk about how erections actually occur. In order for an erection to occur, there actually, as you well know, has to be arousal. And basically the nerves that are insinuated in the skin around the penis basically become stimulated. And those nerves then travel up in the spinal cord into the brain. And the brain then sends a signal back down to the penis to cause relaxation of the muscles in the blood vessels of the penis. And those blood vessels therefore dilate or stretch open. And as a result of those blood vessels, mainly the arteries stretching open, blood can rush in to the spaces on the inside of the penis. These are the interior spaces. They're almost spongy tissue in there that actually fill up with blood. As you can see, those spaces are expanding, the blood vessels are expanding, and more blood is rushing in. And interestingly, at the same time that that happens, by expanding these spaces, the veins on the outside, which are the blue structures, which are responsible for draining the penis, actually become compressed so that they don't drain. So you have blood flowing in and you have blockage of the blood flowing out, which ultimately results in a good erection. And this is the same exact picture that I just showed you, that the spaces are filling up through the arterial blood, but the veins, the blue spaces, are getting compressed, which prevent the blood from flowing out. So two things have to happen at the same time. If you talk about what are some of the main etiologies or causes for erectile dysfunction, the three biggies are vascular. That means there's not enough blood flowing into the penis. Diabetes is probably the single biggest medical issue as far as causing ED. And then medication side effects. Many men are on medications like blood pressure medications or antidepressant medications that really can affect the ability to have a proper erection. So we do have to review the medications, the medication history in our patients, and we can potentially, with the help of their primary care doctors, adjust them and can make big differences. But also, as I referred to earlier in my talk, erectile dysfunction can come from prostate cancer treatment, needless to say. And interestingly enough, that men who present with erectile dysfunction as their only symptom, they really don't have any other symptoms or signs or medical issues, it can be the harbinger of these three diseases. That you have to think, if they're presenting with ED, they may ultimately wind up having diabetes, they may ultimately wind up having some underlying heart disease, and may ultimately wind up having some vascular disease or issues with the blood vessels. And this is a similar schematic, which just shows you the breakdown of who has what. Probably the most common, the most common cause of erectile dysfunction are vascular or blood flow problems causing the ED. The second most common is diabetes. The third most common is medication. But there are also other things that can contribute to erectile dysfunction, that being men who've had pelvic surgery or some kind of trauma down in the pelvic area. Different kinds of neurological diseases can cause ED. Different types of endocrine problems or hormonal problems can cause ED too. But the three biggies are vascular, diabetes, and medication. Let's talk about ED and diabetes. According to the census back in 2015, 15.3 million men in the United States have diabetes. Well, that's a lot of diabetes. So a big chunk of those men are also going to have ED as well. And it's pretty known that diabetics just don't respond as well to some of the oral medications that we're going to talk about in a minute compared to men who don't have diabetes. And it also, in diabetes, it seems like the ED tends to be more severe than in a population of patients who don't have diabetes. And also, just as I mentioned earlier, patients who present with ED itself can be a harbinger, and it really should tip you off that maybe those patients might develop diabetes in the future. So why does ED emerge? Why does diabetes cause ED? Well, 60 to 70% of the patients who have diabetes also have some nerve injury from the diabetes, also known as neuropathy or peripheral neuropathy. And remember when I told you about how an erection occurs, I told you that in order for the whole initiation of the cascade of events that happens to get an erection, the first order of business is to have the nerve stimulation. Well, if the nerves are not stimulated properly because they're damaged, well, you can see how that's going to disrupt the whole pathway. Also, diabetes affects the blood vessels. The small little blood vessels that supply the penis can be affected by diabetes. Diabetes affects nerves and blood vessels. So that's where they take another hit. Then the blood vessels have to be intact to get good erections. And also, just a little point that some of the medications that we'll talk about again shortly, the medications that are used for ED, they cause a stimulation in those blood vessels to dilate. Well, if the blood vessels are injured or if the nerves are not working properly, that's why those medications, the oral medications like the Viagras and the Cialises, et cetera, that's why they don't work so well in the diabetic patients. So as we mentioned before, you've got to have nerve stimulation, and that's clearly probably the biggest reason why diabetics have an issue. So what are some of the factors that may increase the incidence of erectile dysfunction in men who have diabetes? Well, as you get older, it gets a little bit worse. It's affected by how long you've had diabetes. So the longer you've had diabetes, the longer the opportunity is given for those nerves and blood vessels to be affected. If you have poor sugar control, if you don't have good blood sugar control, your diabetes is out of control, so to speak. That's going to affect ED a lot more. If they have associated underlying vascular disease with the diabetes already, well, that's going to make the ED worse as well. Men who are taking diuretics for their hypertension, in addition to their diabetes, that's going to combine to make the ED worse. And finally, a lot of men who have diabetes also have underlying heart disease. So the combination of diabetes with heart disease, well, that's going to make the ED even worse too. So you can see on many fronts why diabetes really can be a very significant etiological factor for making ED a significant problem in men. Let's talk about heart disease. The symptoms of heart disease may develop within 2 to 3 years of ED. Remember that earlier slide that I showed, that if patients present just simply with erectile dysfunction, you really have to think that there could be underlying heart disease and that they may in fact develop heart disease soon if they have ED. They do kind of go hand in hand. And interestingly enough, look at the statistics. ED precedes coronary artery disease symptoms. That means diseased arteries in the heart itself in almost 70% of the cases. So ED and coronary artery disease are very much correlated together. That's basically a repeat of what I just said. So let's look at some of the blood vessels that are in different organs in our body. And remember, in order to have a proper erection, you have to have good blood flowing in. You have to have blood vessels or arteries that are of good caliber, have a good lumen, meaning there's a big central space in those arteries to get the blood flow in. And if you ultimately get narrowing of these blood vessels, then you're going to affect the ability of the blood to get into that particular organ. And in the case of erectile dysfunction, you can see that the penile arteries are already quite small compared to an artery that supplies the heart, or an artery that supplies the neck and head, or an artery that supplies the groin and the thigh. So relative to this artery, the penile arteries are very, very small. So if you get hardening of those arteries or calcification or atherosclerotic plaque, which is the stuff that builds up inside of arteries, you're going to get restriction of the blood flow and you're going to get poor erections. But this schematic is basically showing you how small these arteries are to begin with. So it doesn't take much to pinch them off. Now, you can reduce your risk of erectile dysfunction by improving your health. There are things that you can do to help control yourself and improve things for yourself. Well, these are things we already know. There's not one single thing on this list that you don't already know to be good for you, whether it's to improve your circulation in general, to improve your erectile dysfunction, to improve your heart, to improve your blood pressure, to improve your overall well-being. You can help yourself by controlling your diet, which means don't eat excessive salts, don't eat excessive proteins, don't eat a fatty diet. So we know that diet plays a role. Exercise and physical activity plays a role. The more active and physical you are, you're going to prevent plaque buildup in those blood vessels. We know that obesity affects ED. Well, if you can control your weight and keep it into some sort of reasonable range, you will help yourself as far as ED is concerned. And absolutely, with respect to smoking, we know that smoking is a killer for blood vessels. It causes complete narrowing and restriction in the blood vessels. So it makes sense to stop smoking. And then, of course, reduce your stress. Pretty easy as 1, 2, 3, right? Reduce your stress. You're gonna work out. You're gonna reduce your erectile dysfunction by gobs. Well, we don't know that that's a direct correlation, but certainly all of these things are important to improve your overall health and improve your overall circulation and improve, therefore, your overall sexual functionality. What about erectile dysfunction and low testosterone? Men come in to see me all the time because they're convinced that their testosterone levels are low. Well, when there is low testosterone in men, it can potentially lead to exacerbation of their erectile function. And low testosterone is more common in men who have obesity. Here comes the diabetes thing again, high blood pressure, high cholesterol, prostate disease, or asthma, or this is chronic obstructive pulmonary disease. So men who have pulmonary or lung issues tend to have low testosterone levels as well. And if you look at this piece of information, about 4 in 10 men over the age of 45 have low testosterone. So 40% of men over the age of 45 are going to have low testosterone levels. And for every 10-year increase in the age, the testosterone level goes down 17% per decade, essentially. So it's real. Testosterone levels do need to be maintained in normal levels. It's not that it's the be-all, end-all answer for all men who have ED, but if you have ED with low testosterone and there's no contraindication to treating those patients, they should be treated with testosterone supplement to get them back into normal levels. So if you have low testosterone levels, and that's simply diagnosed by simple blood tests, actually, there's many ways of treating it with either testosterone gels that are rubbed onto the skin. There are testosterone patches that can be placed on the skin. There are now new oral testosterone medication supplements, and also there are testosterone injections. And you can discuss with your urologist which one of those seems the most appropriate for yourself. Let's talk about prostate cancer treatment, which I alluded to in the beginning of my talk tonight, and how I ended up getting myself involved in erectile dysfunction treatment in the first place. But just a little bit of anatomy. There are these, this is the bladder, this is the prostate, and that's the urethra, the urinary channel that goes through the prostate and eventually out the penis. Well, alongside the prostate, there are these little nerves and blood vessels that live there. And these nerves and blood vessels are very important for the attaining of proper erections. And when we remove people's prostates, or when patients are getting radiation treatment to the prostate for prostate cancer, these nerves and blood vessels get in the way, and they can be affected by either the surgical treatment or the radiation treatment. So many men who ultimately have treatment for their prostate cancer excuse me, can develop erectile dysfunction, whether temporary or permanent. From a surgical point of view, we know where these nerves are located. And when we're doing our robotic prostatectomy surgery for prostate cancer, we try to peel these nerves off and spare them. We try to do a nerve sparing prostatectomy. And we can save the erectile ability in most men in most situations if the cancer isn't too extensive. But you can see on this schematic, it's a little bit larger. You can see it a little bit better, how close the nerves actually come to the prostate. And when you're removing the prostate for cancer, you have to cut across there, you have to cut across there, and then you have to put the bladder back together with the urethra. That's what's happening here. But in this case, you can see that the nerves were spared, and we're able to take the prostate out, spare the nerves, and put Humpty Dumpty back together again, so to speak. But this is how we do a nerve sparing operation. Sexual dysfunction, I want to kind of summarize this slide, but people ask me this all the time when they come in for treatment for their prostate cancer. Am I better off having radiation treatment for my cancer? Am I better off having radical prostatectomy for my prostate cancer? And the answer is, it depends on your age, it depends on the stage and grade of the cancer, it depends on your overall health. And we make that decision individually for each patient uniquely. But sometimes patients want to make a decision about their treatment for their prostate cancer based on which one will cause less erection problems. And interestingly enough, it's identical whether you choose prostatectomy surgery or radiation. About 50% of men, half the men, will have some degree of difficulty with erectile dysfunction. It doesn't mean that you can't improve it for them and make it better and resuscitate it and rehabilitate it. But just I want you to know that I generally don't recommend for men to decide which treatment they should pick for their prostate cancer based on erectile function, because no matter what you pick, it's almost identical with the surgery or the radiation. I just want to segue into something that's completely separate from what we've talked about a little bit, in that it's a different disease entity called Peyronie's disease that can cause erectile dysfunction. And essentially what Peyronie's disease is a curvature of the penis that results from scar tissue buildup in the inner layers of the penile shaft. And this theoretically comes from little traumatic tears that develop deep inside the penis. And because it tears, it ends up forming a scar tissue area. And as you well know, the penis, which is spongy, normally has to fill up with blood. Well, if you have scar tissue there, it can't fill up completely with these areas of scarring. So it causes a curvature when it tries to fill up. And there are treatments that you can give for Peyronie's disease. You can excise these little pieces of scar tissue. You can put stitches on the opposite side to sort of force it to curve the other way. There are different medications called Xiaflex that you can inject into the scar tissue to soften it up. And there's also penile implants, which we're going to talk about in a minute, which are devices that are placed inside the spongy tissue of the penis, which will not only help them with their erection problems, but it will end up straightening out the curvature. So let's move on to some of the other treatment options that you might be familiar with for the treatment of erectile dysfunction. Oral medications, we're talking about the Cialises and the Viagras and those kinds of medications. Penile injections, where actually you take a medication that actually Northern Pharmacy compounds for us. Those are the compounding medications I was referring to earlier. They're usually a combination of 2 or 3 medications that are mixed together that are injected into the side of the shaft of the penis. I think I have I'll get into more specifics later, but they actually will cause significant dilation of blood vessels in the penis and ultimately result in a good erection. Vacuum erection devices, which are external devices or pumps that can help get an erection and ultimately be used for intercourse. They're little tiny urethral suppositories, or little tiny pellets that are actually put down the urethral hole where you urinate from, that can help dilate blood vessels and get blood flow in there. And finally, penile implants are the devices that we can implant into the spongy tissues of the penis to ultimately result in permanent erectile dysfunction reversal. We're going to talk about all those. So let's talk about the oral medications. They're also called PDE5 inhibitors. Those are like the Viagras and the Cialises and stuff like that. And the bottom line is they increase blood flow to the penis. They cause dilation of the blood vessels, and it can cause more blood to rush in. It usually is effective in about 60 to 80% of cases, but it's a matter of, how effective. Some are better than others. Some medicines don't work at all for people. Some medicines work great for people, but it's certainly worth a try. There are many side effects, including headache, facial flushing, and an upset stomach or reflux symptoms. And we can sometimes abate some of those symptoms by treating them, but we can also switch to a different medication, and you might not have the same type of side effects. You also have to talk to your doctor if you're on an alpha blocker medication, which is the medicines that we typically give for an enlarged prostate. You probably shouldn't necessarily take these medications together. And people who are taking nitrates or nitroglycerin, it's an absolute contraindication against taking these kinds of medications. You should not take them. So we talked about how they work, the side effects, and some of the precautions. Let's talk about the injection therapy. This is the picture in a slightly enlarged version, which shows the patient is actually injecting the triple medication, the double or triple medication, into the side of the shaft of the penis. On this cross section, you can see this little tiny needle goes into that spongy space, and that causes the blood vessels to dilate and causes the blood to rush in. And that's what ultimately results in a good erection, usually within somewhere between 5 and 20 minutes. The needle that we use is quite small. If you've heard some of these advertisements on the radio about these men's health clinics, that's usually what they're talking about. They basically dispense these injectables, and they will charge you thousands and thousands of dollars for these injectables. You don't need to go to those clinics because we as urologists can prescribe them for you. You can go to an outfit like Northern Pharmacy and get a bottle of this stuff for $100 or $150, which will probably last you for 30 injections. It's actually incredibly cheap if your insurance does not cover it, by the way, which a lot of times they will. But it's incredibly cheap and efficacious, and I'm really asking you to steer clear of some of those men's health clinics. I just put a plug in for that. But I should also say that sometimes men don't like the penile injections and they discontinue them because it causes penile pain. Sometimes it causes prolonged erections that are basically longer than you want them to last for. Excuse me for a second. Sometimes they last a little bit longer than you actually want them to last for. So you have to be careful with this medication too, and you have to do it under the care and protection of your urologist. They should teach you how to do it properly, but it is an option for some men. Okay, so we talked about that. Let's talk about the vacuum erection device. That's that external plastic cylinder that you can see is being placed over the shaft of the penis, and it has a pump mechanism which helps draw the blood into the penis. And once the penis is firm, you have to take that cylinder off and you put sort of a ring at the base of the penis to keep it firm. This is an option for men. In fact, I use it almost routinely for men who've had prostate cancer surgery, and I use this in the beginning for them to rehabilitate their sexual function. But it is a little bit uncomfortable. It is a little bit unwieldy, and men don't necessarily want to use this type of device in the sense that by the time they get all this accomplished and they get back into the bedroom, half the time their partners are already asleep. So it's not exactly spontaneous or pleasant, but men are also willing to try just about anything to achieve a proper erection. So this is an option and should be discussed. The urethral suppository, I'm really not going to talk about too much because I almost never use it anymore. I find that between it not working half the time or causing too much discomfort, I really haven't had very much success with it. So I'm just going to pass on that. Let's move now into the penile implant portion of this presentation tonight. And I'll just do a couple of intro comments. How do these things work? Basically, by squeezing the pump, which is the little device that we put in the scrotum, it moves fluid, it transfers fluid from a reservoir, which is a plastic device that's placed behind the pubic bone, behind the bone that's way down low in your body. It transfers fluid from this reservoir into these couple of cylinders that are put inside the spongy space of the penis. And by transferring the fluid, these cylinders fill up and you develop an erection in the penis. All of this stuff, the pump, the reservoir, and the two cylinders, can be put in through a very tiny incision on the undersurface of the penis, either there or the base of the penis there. Very small incisions. You can put all of these components in. And when they're inside the patients, they're totally concealed. And you could walk around naked in the gym and no guy would ever know that you had this device inside of you. So it's very easy to put in and very concealable. So it's quite nice. About 98% of patients are usually quite satisfied with this device and would describe their erections as quite good. The main side effects from the device is that it can cause some postoperative pain. Well, that kind of makes sense. If you're doing surgery on the penis, there is going to be some pain, but we give you plenty of pain medicine to go home with, and we usually recommend that you stay at home for about a week and you use ice packs for 48 hours. There also is about a 5% chance that in your lifetime, there could be a mechanical malfunction of the device, and that's very rare, but it can be dealt with quite easily. So we talked about how it works, how effective it is, and some of the side effects. These are the different types of implants that are produced by the Boston Scientific Company. There's really only 2 companies that even make these type of implants, and there's a third company that has now a rigid implant. But the difference are the types of implants that I use almost exclusively are these, because they're inflatable, and when you don't want to use it, it's deflatable and natural and soft and comfortable. This is the most sophisticated type of implant that's really out there on the market and gives the patient the most natural erection and the most natural deflated state. This type of device is just a semi-rigid cylinder that's placed in the penis. There is no pumping mechanism with it. It's bendable, but it cannot be compressible. So you always walk around a little perky, if you will. And this type of device, which I really don't use too much anymore, is a hybrid maybe between this one and this one. It is inflatable, but there's no reservoir associated with it. So you don't get quite the erection capability as this one, and you don't get quite the deflation ability as you would with this one. So these are the most sophisticated ones, and if you're going to a urologist, you really want to make sure that they're capable of doing these types of implants for you. Most of these implants have antibiotic coating on them. And that antibiotic coating that's built into the implant itself has really reduced the number of infections that we see with these implants. So we almost never see infections, or not too often, at least not in men who are not diabetics. Diabetics do have a higher incidence of having infections, but even with them, it's pretty rare to get infections. And we think that the impregnation of the device with the antibiotic has really reduced the amount of infections in these patients. So that's been a major plus in the development of some of these implants. I was going to show you a little schematic video just to show you how the implant actually kind of works. So just watch along with me. So these are the 2 cylinders that are in the spongy spaces of the penis. And those spongy spaces actually go behind this pubic bone deep inside. And we measure the cylinder based on the full length from here all the way to there. So every patient is very much different. Every patient is measured specifically for them, and we have to size them appropriately for your size. Every man is not created equal. This is the pump that's in the scrotum. We usually put it towards the front of the scrotum, away from the testicles, so that the patient can easily feel it and know exactly where the pump pump up part is and where the release valve is. So that's where that part is put in. And the reservoir is this sort of, it looks like basically a water bubble that's placed behind the pubic bone, way down in the lower part of the body. So it's concealed and will never be felt. And that's actually the source of the fluid that gets transferred into these cylinders once the pump is pumped. And all these components get put in through a tiny little incision on the underneath side of the penis or on the top of the penis based on the surgeon's preference. So this is the patient deflating the implant, and the fluid now then transferred back into the reservoir. So a few more things about the penile implant. It's usually performed as an outpatient procedure under general anesthesia. We have beautiful state-of-the-art updated outpatient surgery centers, and they're perfectly suited for this kind of thing. We virtually never do it in the hospital anymore. I told you it's basically a small incision. We basically recommend patients staying home for a week. They definitely can go back to work in about a week. They're able to move around the house. They're able to take a shower. They're able to go to the bathroom normally. They're able to go to the kitchen and fix themselves something to eat. But I generally recommend that they stay home for a week. We will bring the men back a day after the surgery to check on everything, a week after the surgery to check on everything, and somewhere in the 4 to 6 week period after the surgery, we actually bring them back to show them how to use the device. Interestingly enough, the insurance coverage for erectile dysfunction treatment varies for some of the other treatments, but is actually pretty good for penile implants. Medicare absolutely will cover penile implants, and especially if men have a secondary insurance on top of their Medicare, virtually the whole thing should be pretty much covered. But Medicare will cover 80% of the cost of the implant, and hopefully with a secondary insurance, the other 20% is covered. But nonetheless, insurance coverage is pretty good. We don't set patients up for these implants without doing a pre-authorization with the insurance company and make sure that it absolutely will be covered before we do it. But it's actually pretty good. And for men that don't have secondary insurances or may have a financial hardship, the company can work with them, and we can work with them too about payment plans and different other types of compassionate assistance that we can offer them. These are just two patients that had a penile implant, John and Cliff, and one had diabetes with high blood pressure and the other guy had prostate cancer. And you can see some of the comments that go along with these penile implants. These men feel like they really got their self-esteem back. They feel like they got their life back, although obviously it's not life and death. And obviously sometimes we chuckle about these kinds of things. But if it happens to you, it's not exactly a chuckling matter. And it does bring back intimacy into the marriage and into the relationship. So it is very crucial for men to have what I think is, a happy and healthy sex life, although not crucial for a life. It is crucial for self-esteem, intimacy, and good relationships. So we do know that penile implants have proven patient and partner satisfaction. You can see these statistics are just out of sight. Somewhere between 97, 98% of patients are really happy with it. As mentioned, it's pretty much covered by insurance. It is long lasting, it's permanent, it's concealed and durable. 89% of the men who have them put in for the first time still use it after 10 years. And it's a natural solution. Basically, if you're lying around in bed and the moment is right, within 5 to 7 seconds of wanting an erection, you get one, and it's going to be sustainable and it's going to be reliable. And then after you have your sexual experience, you pump the thing down and it's natural and comfortable. But in some ways, it's better than the real thing because 100% of the time it's going to work. It can stay up as long as you want it to stay up. Your partner can have multiple orgasms. And when you're done, you can command it, so to speak, to go down by pushing the deflation button. It is spontaneous and it brings back all the spontaneity back to your relationship. As mentioned earlier, there are risks with any surgery, and including with this surgery. The main risk is that it can malfunction over time, although small, that it can get an infection over time, although very small, that it can lead to some curvature of the penis, although very unlikely. Those are the main things that we see, but even with those, we rarely see these complications. It's really been quite a boon for men who have this issue. And interestingly enough, despite what you might think, penile implants have been around for over 50 years. This is not newfangled technology at all. It was invented quite a while ago, and the person who invented it probably should have won the Nobel Prize. Needless to say, it's a little more sophisticated today than it was then, and the materials that are being used for the devices are better and more durable, but the basic concepts of what were involved in penile implants were exactly the same as they were then. So just to summarize then, ED is a very common problem and it's associated with many other medical conditions. There are a variety of treatment options, and in order for you to get those treatment options, you really probably should see a urologist that specializes in ED. And also penile implants can offer a long-lasting, very satisfactory solution. I want to thank you all for coming tonight, and if you stick around, I will answer the questions that were submitted.